Good afternoon, Myglip. On behalf of Zydus Cadilla, let me welcome all the doctors and healthcare workers for joining today's symposium. My name is Ram, the country head for Zydus Cadilla. We know that it is almost 8 months now. We started adjusting to the new normal in coping with COVID and to live and serve our patients. And we definitely take a special note on your commitment to serve for the well-being of the society and your patients, and we really appreciate. It is my pleasure to welcome Professor Aung, Professor, Head of the Department, Mandalay General Hospital. She is also the President of Myanmar Society of Endocrinology and Metabolism, and she has been spearheading in creating and fight diabetic mellitus in Myanmar. And we really appreciate her work. And let me take the pleasure in welcoming Professor Koko, Head of the Department, University of Medicine 2. And he's also the General Secretary of Myanmar Diabetic Association, Vice President of Myanmar Society of Endocrinology and Metabolism. And we all know that, we are all very interested and keen to listen to his very livid discussions he's going to make today. And it is my honor and privilege to welcome Padma Shri Professor Shashank Joshi. He's an eminent endocrinologist from India. Welcome, sir. And Professor Shashank is an international personnel with his invaluable contributions to the world in fighting and managing diabetic medicine. And just I want to talk about this, the honor he has conferred. It has been conferred on him. So Padma Shri Award is conferred by Government of India for the invaluable contributions made to the medicine, social welfare, etc. And this award was initiated in 1954 by Republic of India. And till now, we have about only 3,005 Padma Shri awardees in a population of more than 1 billion plus. So it really speaks about the value of this award, which has been conferred on Padma Shri Shashank Joshi. And welcome once again, sir, for this session. And we actually, we missed your session 2 years back when we wanted to have you here in Myanmar. Unfortunately, we were, due to some reason, you could not make it. But we look forward, sooner to have you here in person to hear your lecture and sessions. And let me also take pleasure in welcoming Dr. Hardik, our medical affairs head, who has been providing us with the new research updates. And I welcome our respected professors, Professor Utinsile, Professor Tantai, Professor Kinsoten, who has also joined this session. And it is our pleasure and privilege to talk about Myanmar, because we know that we have a factory has been created in Yangon for the production of manufacturing of drugs to attain a self-reliance Myanmar. And it's a proud moment for each one of us because already about 40 products are being produced from our Telawa factory here, reaching to our patient. And what is more, Myanmar will get its first Gliptin by its own manufacturing. So we call Myanmar's own Gliptin is Myglip. It is going to land in your hand very soon in the first week of January. And we keep our mission very clear that, the medicine should be available to every patient who lives in Myanmar and it will be affordable. So that is our promise to the people of Myanmar. And we look forward for an interesting symposium. And I request Professor Aung for our opening remarks, and I hand over the session. Over to you, Professor. Thank you very much.
Hello. Hello, Myglip. Good afternoon, everybody. I am really pleased to welcome all of you to the very interesting symposium on the management of diabetes in resource-constrained settings. So, as you all know, the prevalence of diabetes is rapidly increasing. According to IDF, in 2019, 460 million adults were living with diabetes worldwide, and nearly 80% of these people were living in low and middle income countries. So So not only prevalent, diabetes also carries the tremendous morbidity with very high health expenditure and shorter life expectancy. So we've been trying to control this problem by various approaches. What are these approaches? And actually, the last decade has been the most exciting time in diabetes research ever. There were a lot of cardiovascular outcome trials, which opened the new chapters in management of diabetes, with improvement in renal outcomes, cardiovascular and all-cause mortality. We do appreciate the enormous effort of researchers and clinicians who were involved in these development. However, there are some factors to be considered in our resource constrained settings like availability and affordability. I think you all accept the fact that consideration of the cost is an important component of effective management. Cost has a huge influence on adherence. That's the main thing. There is usually a gap between the efficacy of these medications used in the randomized controlled trials and the effectiveness of that particular medicine in the real world use. Why is that? Today, we are very fortunate to have two eminent speakers who are going to resolve these issues. So, the first speaker is Professor Koko. And actually, he does not need any introduction. He is a very well-known diabetologist of our country. And he is the professor and head of the Department of Endocrinology, University of Medicine 2, Yangon. And he is the program manager of the WHO project for prevention and control of diabetes in Myanmar. And he is the focal person in strengthening public health capacity to respond to Myanmar's disease transition, and also actively involved in diabetes food clinic program with World Diabetes Foundation. And so who else is better than to tell us about the situation of diabetes in Myanmar? And he is going to discuss about the various approaches to tackle the enormous problem of diabetes in our country. So please welcome Professor Koko. Thank you.
Thank you, Madam Chair, for your kind introduction. And good afternoon to everyone. And greeting from Myanmar, Professor Shashank Joshi. I'm very honored to talk together with Professor Dr. Shashank Joshi. He's a very famous diabetologist in the India, and we can have many good things and from hearing from him. So I just want to request Professor Shashank Joshi. I will be talking in the bilingual, mainly in the Myanmar language in this talk. Thank you. And then I will share my slide now. And today, my job today is to talk upon the diabetes management. Mainly, are you going for a guideline approach or algorithm approach, or we are going for the personalized approach, especially in our country, like resource limiting country. So my topic today is guideline or patient-centered approach. So these AI go jilayin zero general serio yuye kama management ma nataushim matami ga general the CJO jali kaungle HbA1c jali kaungle be no HbA1c intensively chain modality mobility tatare so the concept ne general HbA1c diga Tabi general no kubare Tao glucose centric approach lo kaware zero general yure kamale general diga A1C minya jare zero general yura pibare 2008 ko yaw la de kama the HbA1c the lower the better, but you have to choose the drugs without weight gain, without hypoglycemia and side effects of your 2008လောက်မှာဈေးတွေရွေးတဲ့အခါမှာစီးကြိုလဲကြမယ်သို့တော့ weight gain လည်းမရဘူး hypoglycemia လည်းမရဘူး side effect လည်းနေရမယ်စီးကိုရွေးရမယ်ဆိုပြီးတော့ concept ကပြောင်းလာပါတယ်2018မှာကျတော့ mainly they are focused on cardiovascular risk. Babuleto, see you the Mari, Diga bin Tiraga, Tenora, non alone to Georgian, Lipianet, Tira, Pit job, cardiovascular risk, Diga Tabio, risk-based approach to glucose-centric look for it, not A1C, Charlie approach and risk-based approach to not only glucose control, but also we need to go for blood pressure reduction, LDL cholesterol reduction, and you have to choose the drugs, the glucose lowering with the agent of proven safety and efficacy. So your general dilo concept piang la rao general tuya. If you want to start to give the medication, or if you choose a medication for diabetes, you have a 3 approach now. This is a guideline approach, or a pathophysiological approach, or patient-centered approach. This is the pathogenesis of the type 2 diabetes. And then previously, we know that because of the insulin deficient or insulin resistant, that diabetes occur. That's why one hormone theory, insulin machine, later on, they have a 2 hormone theory, insulin machine, pidasya nematonailo. The chain mare, the diabetes the marima, the pancreas machine alpha ne glucagon nyai to doubt to yare. Glucagon and the insulin effect the jamu glucagon myalo, see you pide, so your 2 hormone theory to lavare. Now, some by maro, 3 hormone theory, young lavare. 3 hormone theory about insulin nelo, see you pide, glucagon myalo, see you pide. The chain mare, general GI track and if your incretin hormone nelo, see you pide, the jamu. The hormone 3 hormone theories are 12. I general the pathophysiologically so in general paid area, matica, insulin o meow loame, glucagon neo loame, incretin o meow loame, so your general Dilomio 3 hormone theory don't correct look 9 series, Yabu to do about it. I think Kama, general, let's see Tony a series like their Kama, incretin based therapy gave. The 3 hormone theory can correct look name mare. General Miado don't metformin the general insulin resistant dore. Safuna you are the insulin production utonal dore. The Tomio the longo 3 hormone theory Tivo daga only incretin based therapy can correct 3 hormone defected at the job. Incretin based therapy generate diabetes management ma yan yeji lare, pathogenesis yan yeji lao to shiavare. Now, by general, the pathogenesis of diabetes are no general certain mubo area certainly allow the pilavare, imaginal Chile, pancreatic beta insulin matrualo, incretin nelo, alpha seri, ma divio, increase glucagon mialo, now insulin resistant pito, brain and video, no general dopamine nelo, coloma, piatanashilo, immune system tilo. Stomach ma delay emptying pillow. Now, W kidney reabsorption power in Mialo Subio. Below pathogenicity, set a mutual karma. Saro Chile, incretin based therapy, the general Toro Mamia Mava, the pathogenicity, Mania Chaunia Loga. Now, incretin based therapy, pay ma darling, Pian Kaula Nino, General Tuyavari. The young general Ninia. Peter say, and if you insulin 12, Savana Urian. Don't name Damamolo I near my incretin up, no glucose independent, no insulin secretion of Chesire. Chain money, alpha said, Draco General, incretin it don't me, insulin resistant, metformin or dizzy dome, as you do in Midasro. Safona urea, metformin or dizzy, incretin base, no, general as you do in Bedai, Dilo label that be line. All the pathogenesis kava pit or out to share. The young pathogenesis approach ya gene, general nine, pese the mure gamma, general pathogenesis a colo kava machinine. The young Dimaro, incretin based therapy, general Dimagila and GLB1 to be before the insulin regulation, insulin resistant, madonna, kidney, brain, colon, totom, yama. incretin based therapy most of the pathogenesis ကို target လုပ်ထားတယ်တွေ့ရတယ်ဒီအချက်က pathogenesis approach ကဘာပြောလဲဆိုတော့ကျွန်တော်တို့ pathogenesis ကိုအကုန်လုံးကိုထိနိုင်ဖို့အတွက်ကဆေးတွေကိုပေါင်းသုံးမှရမယ် sulfonylurea metformin or Defect SGLT2 inhibitor incretin တွေပေါင်းပြီး most of the pathogenesis ကိုကျွန်တော် correct လုပ်နိုင်မယ်ဒီဆေးတွေထဲမှာမှ incretin based therapy ဟာ targeted most of the pathogenesis ကိုဖြည့်တဲ့အတွက်ကြောင့်ကျွန်တော်တို့ရဲ့ management of the type 2 diabetes မှာ incretin based therapy ဟာ pathogenesis approach အင်မတန်အရေးပါနေတယ်ဆိုတော့ကျွန်တော်တင်ပြပြသည်နောက်တစ်ခုက 2020 ADA guideline ထွက်လာပါတယ်ဆရာတို့အားလုံးလည်းဒါရင်းနှီးပြီးသားဖြစ်ပါမယ် You all are familiar with this algorithm so we start with the metformin next to metformin they have a two line one line is one people there's an indication for high risk of established ASCVD or CKD or heart failure if you had that one you go for GLP-1 or SGLT2 တကယ်လို့ ASCVD မရှိဘူးเนาะကျွန်တော်တို့က CKD heart failure မရှိရင်တို့က3 approach နဲ့သွားပါတယ် hypoglycemia ကိုနည်းစေချင်တာလား weight gain ရသည်ကိုနည်းစေချင်တာလားဒါမှမဟုတ် cost is the major issue လားဆိုပြီးတော့သွားပါတယ်အဲ့တော့အခြေအကျန်ချက်ကြည့်ရင်ဆရာတို့က next to metformin မှာ ASCVD ရှိရင်ကျွန်တော်တို့က GLP-1 or SGLT2 with proven CVD ကိုရွေးသုံးရမှာဖြစ်ပါတယ်ဒါနဲ့မှမရရင်တော့เนาะကျွန်တော်တို့ကSGLT သုံးနိုင် GLP-1 မသုံးနိုင်ရင်တော့ DPP-4 ကိုသုံးရမှာဖြစ်ပါတယ်မရရင်တော့ basic insulin Defect sulfonylurea ကိုသုံးရမှာဖြစ်ပါတယ်တကယ်လို့ heart failure နဲ့ CKD နဲ့ predominant ဖြစ်ရင်တော့ SGLT2 က main ပဲကာကွယ်ပါတယ်တကယ်လို့ဒီမှာတော့ Defect ကို avoid လုပ်ရမှာဖြစ်ပါတယ် and then metformin SGLT2 နဲ့မှာ control မရရင်တော့ကျွန်တော်က next to မှာ GLP-1 or DPP-4 ပေါ့နော်နော်ဆက်စ Gliptin တော့မတော့အောင် basic insulin sulfonylurea တော့ရမယ်ဆိုပြီးတော့ကျွန်တော်တို့ကဒီ study ဒီ trial ရဒီ algorithm ရ DPP-4 ရ third line မှာပါနေအောင်ကျွန်တော်တွေ့ရပါတယ်တကယ်လို့သာ hypoglycemia priority ဖြစ်နေတော့ DPP-4 နဲ့စပါ SGLT2 ကိုသုံးပါအော်မရရင်ကျွန်တော်တို့အခြားအနေနဲ့ sulfonylurea basic insulin သုံးလို့ရပါတယ်ဆိုပြီးတော့ကျွန်တော်တို့ compelling needs for hypoglycemia ပေါ့နော်တကယ်လို့ weight အတွက်ဆိုရင်တော့ SGLT နဲ့ GLP-1 ထိဆုံးမှာရပါတယ် GLP-1 ကိုမသုံးနိုင်လို့ရှိရင်တော့ကျွန်တော်က DPP-4 ကိုသုံးတာလို့ရပါတယ်တကယ်လို့ဒါ money is the issue cost is the issue ဆိုရင်တော့ you start with the metformin sulfonylurea Defect ပေါ့နော်ဒါအကောင်းဆုံးဒီပဲတကယ်လို့ဒါအဲ့ဒါနဲ့မှမရရင်တော့ basic insulin ကိုကျွန်တော်တို့သုံးလို့ရပါတယ် or DPP-4 SGLT with lowest acquisition cost ပေါ့နော်တဘောကတော့ကျွန်တော်တို့ဘာလိုလာလဲဆိုတော့ sulfonylurea metformin sulfonylurea Defect သွားမလားသို့မဟုတ် metformin sulfonylurea insulin သွားမလားသို့မဟုတ် metformin sulfonylurea เนาะ DPP-4 very low cost ပေါ့နော်အဲ့တော့ကျွန်တော်တို့နိုင်ငံမှာတကယ်လို့ဒါ DPP-4 ဒါဈေးပေါ်ပေါ်တက်တက်တာနဲ့ရမယ်ဆိုရင်တော့ this is the best combination ဖြစ်ဖို့များပါတယ် even though ကျွန်တော်တို့ကเนาะ cost က major issue ဖြစ်နေmetformin sulfonylurea with very low cost เนาะ DPP-4 inhibitor ရရင်တော့ဒါအကောင်းဆုံးနည်းပဲဖြစ်တယ်ဆိုတော့ကျွန်တော်တင်ပြပြသည် SGLT2 GLP-1 တွေဟာဈေးကြီးနေပါသေးတယ်ဒါကြောင့်မို့ကျွန်တော်တို့နိုင်ငံအတွက်တော့လက်သက် at the moment မှာ resource limited country တွေကတော့ just like window shopping လိုပဲကျွန်တော်တို့ကကြည့်ပြီးတော့နေရမှာဖြစ်ပါတယ်တကယ်ပတ်စံရှိတဲ့လူတကယ်လိုတဲ့လူဆိုရင်တော့လည်းသုံးရမှာပေါ့နော်တနိုင်ငံလုံးအနေနဲ့เนาะ affordable ဖြစ်ဖို့ကလည်းတိတ်မလွယ်ပါဘူးအဲ့တော့ဒါက Canadian ကကျွန်တော်တို့ကเนาะ Canadian ကနေပြီးတော့ evidence based guideline ညံ့ပြီးတော့သူတို့ဆွဲထုတ်ကြည့်လိုက်တဲ့အခါမှာအသက်တာဆုံးက metformin 2000 mg per day ပြင် metformin ဒုတိယ sulfonylurea မရရင် insulin or Linagliptin ဆိုတာသူတို့ကတွေ့ရပါတယ်ဆိုတော့ဒီလေးမျိုးဒီကျွန်တော်တို့ကဈေးအသက်တာဆုံးဆိုတာတွားတဲ့အတွက်ကြောင့်ကျွန်တော်တို့ကလက်ရှိ baseline မှာကျွန်တော်တို့ပတ်စံတာမရှိရင်ကျွန်တော်တို့နိုင်ငံမှာလည်းအဓိကအဖြစ် resource limited မှာ metformin sulfonylurea ကိုအဓိကထားသုံးနေပါတယ်မရရင်တော့ insulin or Linagliptin ပေါ့နော်တကယ်လို့ဈေးသက်တာနဲ့ရမယ်ဆိုရင်တော့ကျွန်တော်တို့ဒီ combination ကကောင်းဆုံးဆိုတာကိုကျွန်တော်တွေ့ရပါတယ်ဆိုတော့ကျွန်တော်တို့ဆေးတစ်ခုချင်းတွေကိုကြည့်ကြည့်တဲ့အခါမှာ efficacy ကဘယ်လိုနေလဲ next to metformin မှာနှစ်ခုပေါင်းပေးရတော့မယ်ဆိုရင် efficacy hypoglycemia weight side effect cost အဲ့လိုရှင်းကြည့်လိုက်ရင် next to metformin မှာ sulfonylurea ကအကောင်းဆုံးကျွန်တော်တွေ့ရပါတယ်သို့တော့သူ့မှာ weight gain တွေရတယ် side effect ဒီမှာ hypoglycemia ရတယ် cause ကတော့တက်တာတယ် DZ တွေကလည်းကောင်းတဲ့ cause တက်တာတယ်သို့တော့သူ့မှာအဒီမားတွေ heart failure တွေရှိ DPPO inhibitor တွေကို next to ပုံမှန်ပေါင်းရင်တော့ intermediate efficacy ရမယ် hypo ကတိတ်နေသွားမယ်အဲ့ဒါကျွန်တော်တို့လိုချင်တဲ့เนาะ hypo နေတော့စေး weight မတက်တော့စေးเนาะ side effect နေတော့စေးဆိုတာဒါနဲ့တော်တော်သွားကြိုက် only thing ကပတ်စံနည်းနည်းလေးဈေးကြီးတယ်ဒါကြောင့်ကျွန်တော်တို့ကဈေးတက်တာနဲ့ဒါ DPP4 ရမယ်ဆိုရင်ဒါဒီအကောင်းဆုံး combination နဲ့မှာပါတာကိုကျွန်တော်တွေ့ရပါတယ်အဲ့တော့ SGLT2 inhibitor တွေတွားရင်တော့ကျွန်တော်တို့เนาะ intermediate efficacy ရမယ် hypo ကနေတယ်သူက weight loss တောင်ရသေးတယ်ကောင်းတယ်ဒါပေမဲ့ side effect မှာပြန်ကြည့်ရင်တော့ကျွန်တော်တို့က genital tract infection တွေ dehydration တွေရတယ်ဈေးကကြီးနေသေးတယ်အဲ့တော့အောက်မှာနောက်ကထပ်ပြီးတော့သူက durability ဘယ်လောက်ရှိလဲ hypo weight အဲ့ဒါကြီးအကုန်လိုက်ကြည့်တဲ့အခါမှာအနီရောင်ရှိရတွေကမကောင်းဘူးပေါ့ဆိုတော့အနီရောင်အနည်းဆုံးလိုက်ရှာကြည့်တော့ကျွန်တော်တို့ဘာသွားတွေ့လဲဆိုတော့ DPP4 inhibitor တခုသွားတွေ့ DPP4 inhibitor တွေ efficacy လည်းကောင်းတယ် hypo လည်းမရဘူး weight ကလည်း neutral ဖြစ်တယ် side effect လည်းအရင်နေတယ် only thing က cost ဖြစ်တဲ့ကြောင့် if when it can reduce the cost or we can get the DPP4 inhibitor with the low cost this is the best combination ဖြစ်တယ်ဒါကြောင့်မလို့ guideline တွေမှာ second or third line မှာထည့်ထားတာကိုကျွန်တော်တွေ့ရပါတယ်ဆိုတော့ can we this is a feasibility of 2021 EDA guideline မြန်မာအဲ့တော့ဖြစ်နိုင်ကြသုံးနိုင်သလားဆိုရင် yes သုံးနိုင်ပါတယ် we have GLP-1 we have SGLT2 and there's also evidence base is also showing that it's a very good drugs for the ASCVD, CKD, heart failure. Limitation, expensive, SGLT2 cannot stop in EGFR less than 45 and cannot be available in all over the country. ဖြစ်နိုင်ဒါကြောင့်သုံးမယ်ဆိုရင်သုံးလို့ရတယ် limited number of the people မှာကျွန်တော်တို့သုံးလို့ရမှာဖြစ်ပါတယ်เนาะမသုံးနိုင်တဲ့ဘက်ကကြည့်ရင်တော့ဒီ SGLT နဲ့ GLP-1 တွေ not available everywhere in Myanmar is so expensive and less efficacy. Their A1 reduction less than 1 even though very safe and CKD reduction ဆိုတော့ဒါကြ pros and cons တွေပါကျွန်တော်တို့အနေနဲ့အဲ့တော့ကျွန်တော်တို့ရဲ့ diabetic care မှာ the line တွေက high burden of medication non adherence ပေါ့နော်ကျွန်တော်တို့ဈေးကြီးတဲ့ဆေးတွေကို SGLT ကောင်းတယ်ဆိုကျွန်တော်ပေးကြည့်တယ်ကျွန်တော်တို့စီကိုလာတဲ့ခဏမှာခဏသုံးတယ်နောက်ပိုင်းဈေးကြီးတော့မသုံးတော့ဘဲနဲ့ back to other drugs ကိုပြန်သွားတယ် adherence မရှိတာကိုကျွန်တော်တို့သွားတွေ့ရပါတယ် potential health benefit for intensification of medical therapy ကျွန်တော်ကများချခြင်းနဲ့ဆေးတွေကိုတိုးပေးတယ်အဲ့မှာ hypo တွေဝင်တယ် weight gain တွေရတယ်ဒါကြောင့်မလို့ကျွန်တော်ရွေးတဲ့အခါမှာ hypo တွေ weight gain မရတဲ့ဆေးတွေရွေးနိုင်ရင်အကောင်းဆုံးပါ limitation of resource တွေကျွန်တော်တင်ပြသွားပြီဖြစ်ပါတယ်နောက်တစ်ချက်ကတော့ကျွန်တော်တို့ clinician တွေက therapeutic inertia ဆိုပြီးတော့เนาะကျွန်တော်တို့ A1C ကတက်နေလဲလူနာကောင်းနေတာပဲဆိုရင်လူနာအလိုလိုက်ပြီးဆေးတွေမပေးတိုးမပေးပဲနဲ့เนาะကျွန်တော်တို့เนาะ effective drug เนาะ therapy ကိုမရအောင်ပေါ့เนาะ effective target ကိုမရအောင်ကျွန်တော်မကူကြတာရှိတယ်ဒါတွေလည်းကျွန်တော်ရှောင်ရှားမှာဖြစ်ပါတယ်နောက်တစ်ခု international guideline တွေက အဓိကတော့ data တွေကဘယ်ရလဲဆိုရင် resource rich country တွေမှာလောက်ထားတဲ့ data တွေဖြစ်နေဒါကြောင့်လို့တကယ်လက်တွေ့ဘဝမှာကျွန်တော်တို့သုံးဆွဲရမှာအင်မတန်ခက်တာကိုတော့ခက်ပါအဲ့တော့ဒီ guideline တွေမှာဘယ်ကောင်က most evident ဖြစ်ဆုံးလဲလို့ကြည့်တဲ့အခါ overall score အနေနဲ့เนาะကျွန်တော်တို့အရင် popular ဖြစ်တဲ့ ADA တွေ 50% ပဲရပါတယ် ACE 36% ပဲရပါတယ်ဆိုတော့ nice guideline UK ရဲ့ nice guideline က97နဲ့အကောင်းဆုံးဖြစ်ပြီးတော့ Canadian guideline က83လောက်နဲ့ဒုတိယအကောင်းဆုံးဖြစ်တာကိုကျွန်တော်သွားတွေ့ရတယ်ဆိုဒီတိုင်းဆိုရင် evidence base အဖြစ်ဆုံးက nice guideline ဖြစ်တယ်ဆိုတော့ nice guideline 2019ကဘာဆိုလို့ထားလဲဆိုတော့ metformin ကိုစပေးပါ metformin နဲ့ tolerate ဖြစ်တဲ့ control က 7.5 ကျော်တယ်ဆိုလို့ရှိရင်သူက metformin DPP4 ပေါင်းလို့ရတယ်အော် metformin bios ပေါင်းလို့ရတယ်အော် metformin sulfonylurea အော် metformin SGLT2 ကြိုက်တာပေါင်းပါလို့ပြောပါတယ်ဒါ A1C 7.5 ကျော်ဝိုင်းပေါ့တကယ်လို့ metformin ကို contraindicate ဖြစ်တော့ you can go for DPP4 is the first line Parglazone is the first line if A1C 6.5 ဖြစ်နေပေါ့ A1C 7.5 ဖြစ်တော့ sulfonylurea ကိုသွားပါဆိုပြီးတော့ DPP4 inhibitor တွေကို metformin contraindicate မှာ first line နေရာမှာကျွန်တော်တို့သုံးပြီးတော့เนาะကျွန်တော်က DPP တွေကို4 inhibitor တွေကို second line မှာကျွန်တော်တို့သွားသုံးတာပါလေမရလို့ third line ကိုတင်မယ်ဆိုရင်တော့ metformin SU DPP4 ကျွန်တော်တို့ကဒီကောင်ကို suggest လုပ်ပါတယ်ဒါဒီ account pathogenesis yeah general cause that DB4 that cause side effect the best combination metformin sulfonamide DPP4 ဖြစ်တယ်ဆိုတာကျွန်တော်တို့တင်ပြချင်ပါတယ် and then ASCVD ရှိရင်တော့ SGLT2 ဖြစ်သွားမှာပေါ့နော်ပတ်စံလုံးဝမရှိရင်တော့ metformin sulfonamide ပါကလစုံသုံးရမှာပေါ့မရရင်တော့ကျွန်တော်တို့က GLP-1 insulin သွားမှာဖြစ်ပါတယ် so Canadian guideline ကလည်းဗာပြောလဲဆိုတော့ next to metformin မှာ sulfonamide ရမရရင် DPP4 or basic insulin သွားပါဆိုပြီးတော့ guideline ကိုတင်ပြထားတာဖြစ်ပါတယ် so ကျွန်တော်တို့ဒီ resource limited country တွေ mainly ထုတ်ထားတဲ့ IDF ကိုကြည့်လိုက်ရင် IDF မှာ metformin first second line sulfonylurea or မရရင်ကျွန်တော်တို့က basic insulin or เนาะကျွန်တော်တို့က DPP4 inhibitor or DZT or alpha glucosidase inhibitor မရရင်ကျွန်တော်က twice daily ထိုးပါဆိုပြီးတော့လည်းပြောထားပါတယ်အဲ့တော့ metformin sulfonylurea DPP4 အပါကလဆုံးဒါပဲပြန်သွားတာဖြစ်ပါတယ် so WHO ရဲ့ World Organization က 2018 မှာ what should be the second and third line so next to metformin မှာသူက sulfonylurea mainly glycoside ကို second line နဲ့ထားပါတယ် third line မှာကျွန်တော်က insulin or မရရင် DPP4 inhibitor or SGLT2 or DZT ကိုသုံးပါလို့ပြောပါတယ်ဒါရ guideline approach နဲ့ကျွန်တော်တို့သွားတာပါ what about patient center approach ပေါ့ so patient center approach ဆိုတာဘာပြောတာလဲဆိုရင် providing care that is respectful of and responsive to individual patient preference needs and value and ensuring that patient value guide all clinical decision တဘောတော့လူနာဘာဖြစ်နေလဲကျွန်တော်တို့ guideline တော့ဘဒူးလာဝပိန်စင်းရဲချမ်းသာတာ hypo ရှိမရှိဒါဒီ kidney ထိမထိအကုန်လုံး metformin နဲ့စမယ်မရရင် sulfonylurea သွားမယ်မရရင်ပတ်စံမရှိရင်ပါကလဆုံးမရရင် DPP4 inhibitor မရရင် insulin ဒါက guideline approach ဒီမှာကတော့ patient center approach မှာ patient ကဘာကြိုက်လဲဘာလိုနေတာလဲသူဘယ်လောက်တက်နိုင်လဲ patient ကိုယ်တိုင်ကလည်း decision မှာပါတယ်ဒီလိုမျိုးပြောတာကိုတော့ကျွန်တော်တို့က patient center approach လို့ခေါ်ပါတယ်ဒီလိုမျိုး guideline တွေတော်တော်များများဒီနောက်ပိုင်းလူတွေကို patient center approach နဲ့တွားတာဖြစ်ပါတယ်ဆိုတော့ဒီလိုမျိုးတော့မဖြစ်သင့်ဘူးမနော် patient center ဆိုပြီး patient ကိုအလယ်မှာထားပြီးတော့ဟိုဘက်ဒီဘက်လှည့်နေတာဒီလိုမျိုးပြောတာမဟုတ်ပါဘူးတကယ်တမ်းကို decision မှာ patient ကိုယ်တိုင်ပါတယ်ပေါ့နော်ဒါကြောင့်2020 ကစပြီးတော့ကျွန်တော်တို့က goal of the care အတွက် prevent the complication optimize the quality of life အဲ့မှာကျွန်တော်တို့ကပထမဆုံးလူနာရဲ့ lifestyle ဘယ်လိုနေလဲ comorbid တွေက ASCVD CHD အဗီလာဘာရှိသလဲ age တွေ A1C တွေ weight တွေကဘယ်လိုရှိသလဲ depression ရသလားပတ်စံဘယ်လိုနေလဲအဲ့လိုတွေဆုံးဖြတ်တယ်ပြီးရင်တယောက်ချင်းကိုကြည့်ပြီးတော့လိုအပ်သလို individualize A1C target ထားတယ် weight up နော် impact on weight and hypoglycemia ကိုရေးထားတယ် side effect တွေကိုရေးထားတယ် very simple regime ကိုကျွန်တော်သုံးတယ်ပြီးတဲ့အခါမှာလူနာကိုပါရှင်းပြပြီးတော့လူနာကို educate လုပ်တယ် inform to the patient ပေါ့နော် patient preference ကိုမေးတယ် and then effective consultation or motivation တွေ interview တွေလုပ်တယ်ပြီးရင် management plan ကိုချတယ် management ပေးတယ်ပြီးရင် monitor ပြန်လုပ်တယ်ပြီးရင် review ပြန်လုပ်တယ်ပေါ့ဒီလိုမျိုးအနေနဲ့ဒီဟာအကုန်လုံးကို patient center glycemic approach လို့ခေါ်ပါတယ်အဲ့ဒါနဲ့ပတ်သက်ပြီးတော့ဒီလိုမျိုးလုပ်ရမယ်ဆိုပြီးတော့ guideline များတင်ပြသွားတာဖြစ်ပါတယ်ဘာကြောင့်လဲဆိုတော့ကျွန်တော်တို့က one size does not fit for all ဒီမှာကြည့်လိုက်ရင် diabetic elderly ဆိုရင် target A1 ဆိုအဲ့လောက်မှထားမယ်သူလိုလူမျိုးမှာ hypoglycemia မရခြင်း polypharmacy တွေမရခြင်း comorbid တွေများတယ်ဒါကြောင့်ဆေးတွေကို hypo မရတော့ weight gain မရတော့ side effect နေတော့ဆေးကိုရွေးတော့မှာဖြစ်ပါတယ်အသက်ငယ်များချမယ် hypoglycemia မရခြင်းဘူး adherence to the drug ကကောင်းတယ် diabetic nephropathy ရှိရင် hypoglycemia မရခြင်းဆေးတွေရွေးသုံးရမယ်ပတ်စံမရှိရင်တစ်မျိုးဖြစ်မယ်ဆိုတော့ဘောကတော့ပြောချင်တာ diabetic obesity ဆိုရင် choose a drug to reduce body weight comorbid ဒါကြောင့်မို့ဆေးတစ်မျိုးတည်းနဲ့တော့ဒါတွေအကုန်လုံး cover မဖြစ်နိုင်ဘူးဆေးတွေရွေးတဲ့အခါမှာ patient တယောက်နဲ့တယောက်မတူနိုင်တဲ့အတွက်ကြောင့် patient တူချင်းရဲ့လိုအပ်ချက်ကိုမူတည်ပြီးရွေးချယ်သွားတော့ patient center approach ပေါ့နော်ဒါကိုကျွန်တော်တို့ကဒီ current guideline တွေက they emphasize the value of individualized treatment to improve the glycemic control while considering the side effect ပေါ့နော်ဒါတွေကိုအဓိကထားလာတော့ကျွန်တော်တွေ့ရပါတယ်ဒါကြောင့်မလို့ to achieve the glycemic control the current guidelines recommend evaluating therapeutic options using 5 key considerations efficacy ဘယ်လောက်ရှိတယ်လဲ side effect နည်းတယ် hypoglycemia နည်းတယ် weight ကျမယ်တော့ weight neutral ဖြစ်မယ်ဈေးသက်သာမယ်ဟာမျိုးကိုကျွန်တော်တို့ရွေးသုံးသင့်တယ်ဆိုပြီးတော့ပြောပါတယ်အဲ့ဒီအချိန်မှာ pathophysiology နဲ့ individual patient needs ကိုလည်းကျွန်တော်တို့ကဒါရွေးချယ်သွားမှာဖြစ်ပါတယ်ဒါကြောင့်မလို့ဒီ factor တွေရွေးချယ်ပြီးအပြင်ဝါတဲ့လူကိုဘယ်လိုပေးမယ်ပိန်တဲ့လူကိုဘယ်လိုပေးမယ်ကျွန်တော်တို့ရွေးချယ်သွားမှာဖြစ်ပါတယ် hypoglycemia ရှိရင် GLP-1 SGLT2 တွေကိုရွေးသုံးရမှာဖြစ်ပါတယ် obese သမားတွေမှာ GLP-1 SGLT2 တွေကိုရွေးသုံးရမှာဖြစ်ပါတယ် weight reduction weight neutral established ASCVD မှာ GLP-1 နဲ့ SGLT2 တွေကိုကျွန်တော်ရွေးသုံးရမှာဖြစ်ပါတယ် chronic disease GLP-1 SGLT2 နဲ့ Linagliptin တို့ဟာမျိုးကျွန်တော်တို့သုံးရမှာဖြစ်ပါတယ်ဒါကြောင့်ကျွန်တော်တို့နဲ့ဒီ algorithm လေးမှာဆရာတို့က normal weight metformin နဲ့စလို့ရတယ် second line DPP4 second generation S2 ပေးလို့ရတယ်မရရင်ဒီသုံးခုပြန်ပေါင်းလို့ရတယ်မရရင် SGLT2 မရရင် GLP1 ဒီလိုသွားလို့ရတယ်လို့ overweight လို့ပြောလိုက်တာနဲ့ go for metformin မရရင် DPP4 SGLT2 သွားလို့ရတယ် obese ဆိုရင်တော့ metformin SGLT2 GLP1 အကောင်းဆုံးပဲ hypoglycemia ရရင် metformin DPP4 SGLT2 ကအကောင်းဆုံးပဲ CKD 635 မှာ DPP4 လိုဟာမျိုးမှာ Linagliptin လိုဟာမျိုးက dose ကိုပြောင်းလဲကြမလို့တဲ့အတွက်ကြောင့်မလို့အကောင်းဆုံးပဲအဲ့ဆရာတို့ကြည့်လိုက်ရင်ဒီ DPP4 inhibitor တွေအကုန်လုံးဒီ second line generation မှာ all the condition မှာအကုန်လုံးမှာသုံးလို့ရနေတယ်ဆိုတော့ကျွန်တော်တို့သွားတွေ့ရတဲ့အတွက်ကြောင့် DPP4 တွေရဲ့ role တွေက second line မှာရှိနေတယ်ဆိုတော့ကျွန်တော်တွေ့ရှိရပြတော့ကျွန်တော်တို့ဆေးတွေရွေးသုံးတဲ့အခါမှာ clinical trial ကိုကျွန်တော်ကြည့်ရဲပြီးရင်ဒီ condition တွေကိုကြည့်ပြီးဆေးတွေရွေးပြီးတော့တကယ်လူနာလိုအပ်တာကို tailor made လုပ်တာအကောင်းဆုံး method ဖြစ်တယ်ဆိုတော့တွေ့ရှိပါစေတင်ပြပါရစေဒါလည်းတကယ် real world မှာ next to metformin မှာအများဆုံးသုံးတာဒီ sulfonine ယူရဖြစ်ပါတယ်ဒါ2005ကနေပြီးတော့2016တိကြည့်တဲ့အခါမှာ sulfonine ယူရ main ပဲပထမပိုင်းမှာကျွန်တော်တို့ကဗာလဲဆိုတော့ bioglutamine တွေကိုသုံးများတယ် later on မှာသူတို့က4လောက်ထိကြာပြီးတော့ကျွန်တော်တို့ကလေမော်အောင်လေးဖြစ်တဲ့ကျွန်တော်တို့ကဗာလဲဆိုတော့ DPP4 တွေကိုအသုံးများလာတာကိုကျွန်တော်တို့သွားတွေ့ရတယ်ဒါကြောင့်မလို့ DPP4 တွေကတကယ် real world မှာလည်းအများဆုံးပိုသုံးလာတာကိုကျွန်တော်တို့သွားတွေ့ရပါတယ်ဘာလို့လဲဆိုတော့ကျွန်တော်တို့နေ့စဉ်နေ့တိုင်းတွေ့နေကြလူတွေအကုန်လုံးဒီ SGLT2 ကိုလူတိုင်းမှာလိုမှာမဟုတ်ပါဘူး GLP1 မှာလူတိုင်းမှာမလိုပါဘူးလူတိုင်းလည်း ASCVD heart failure ရှိနေတာမဟုတ်တဲ့အတွက်ကြောင့်ကျွန်တော်တို့က SGLT2 နဲ့ GLP1 ဒီလူတိုင်းမှာမလိုတတ်တာကိုကျွန်တော်သွားတွေ့ရပါတယ်အဲ့တော့ကျွန်တော်တို့ရဲ့လက်ရှိကျွန်တော်တို့ရဲ့ဒီ government guideline ကတော့ဒါ algorithm guideline approach နဲ့သွားပါတယ် metformin or glycoside မရရင် metformin glycoside အပေါင်းမရရင် metformin glycoside pioglitazone or metformin glycoside D4 မရရင် basal insulin မရရင် twice daily basal insulin သွားဆိုပြီးတော့ကျွန်တော်တို့ဒီတိုင်းသွားပါတယ်ကျွန်တော်တို့ရဲ့MSAN လို့ခေါ်တဲ့မြန်မာ society ရဲ့ professional guideline ကတော့ the same thing as ကျွန်တော်တို့က nice guideline လို့ပဲ1799အောက်မှာ1နဲ့စပါ metformin နဲ့စပါမရရင်9နဲ့10ကြားမှာ4မျိုးကြိုက်တာနဲ့ပေါင်းမှာ SU TZD TP4 SGLT ကြိုက်တာနဲ့ပေါင်းမှာမရရင်3မျိုးပေါင်းမှာဆိုပြီးတော့ကျွန်တော်တို့က nice guideline နဲ့တူတာကိုတွေ့ရပါတယ် so next to metformin မှာ DPP4 သုံးမလား TZD သုံးမလား so DPP4 ဒီကျွန်တော်တို့ကmoderate improvement A1C ရတယ် low risk of hypoglycemia favorable side effect weight neutral easy dosing and then very appear to be a potential at least to decrease the beta cell apoptosis increase beta cell survival နဲ့ most of the pathogenesis မှာ cover ဖြစ်တဲ့ကြောင့်ကျွန်တော်တို့ကတော့တကယ်တမ်းအကောင်းဆုံးသူကျွန်တော်သုံးရမယ်ဆိုရင်ဒီလို inhibitor အကြိုက်ဆုံးပဲကျွန်တော်ဖြစ်ပါတယ်ပိုက်ဆံလုံးဝမရှိတော့ DZD ကိုသုံးလို့ရပါတယ် DZD ကို15လောက်ပဲကျွန်တော်တို့ကစစေချင်ပါတယ်မရမှ30လောက်ပဲသွားပါကျွန်တော်တို့က45ထိတော့ကျွန်တော်မတင်ပါဘူးဒီမားတွေရနိုင်တယ်ဒါကြောင့်မလို့ renal ထိတဲ့လူတွေမှာသုံးရတာခက်ပါတယ် heart failure သမားတွေမှာသုံးရတာခက်ပါတယ်တနည်းယောက်ျားတွေမှာ bladder cancer ဖြစ်နိုင်ပါတယ်မိန်းမတွေမှာ fracture ပြီးမာတွေဖြစ်နိုင်တဲ့ကြောင့် next to metformin မှာတော့sulfonine ယူရ next to metformin sulfonine ပြီးရင်တော့ကျွန်တော် DPP4 ကိုပိုကြိုက်ပါတယ်အဲ့တော့ how about SGLT2 ပေါ့နော်ဆိုတော့ gliptin နေသုံးပါလား gliflozin နေသုံးပါလားဆိုတော့ DPP4 inhibitor နဲ့ကျွန်တော်နဲ့ဘာကွာလဲဆို A1 ကြီးကြတာကြီးအတူတူပဲဒီဘက်ကတော့ weight neutral ဒီဘက်ကတော့ weight loss ဆိုတော့ဒါတော့ပိုကောင်းတာပေါ့ hypoglycemia အတူတူပဲဒါပေမဲ့ကောင်းတာက DPP4 တွေကဘာ side effect အရင်နေတယ် no Linaglip to Hamusu, check that EGF Piluare, no reported decay machine, Luka Conlecha is the to my other jetty, Nyashiva. Yama, as you are, Kaune Lupiobi me, no siphon, Untra infection, gender infection in my Shivare, EGF 1000 Alma Tolu Miarabau, Glycemic decay, Lepsivare, Kunabore, Luka, pull on to a Miawasi, Tejamlu, together, Generua, Malo, Shin, as you do, sir, develop Tonadi, say a piece on the Timbiaviadi. Pound on your Yala, pound on Wille, General Defect Yas, what no Timbiaviadi. The job, TV Voma, other, no, General County Chetty, Nyaishi Vare, Tivorio Shinjila Lucian Letale, Dr. Shashank Joshi Timbia Doma Pipare, no, they Timbia about, Linaglip, those who Piazia Loam Luau. Linaglip, long life, half life lepsipare, low potent, not very potent devote inhibition, General Yara, Tuyavare, liver out, rename out, General Tono Yavare, glucose, low one efficacy male, just like General Sitagliptin low, no, 0.74% Jara, Tuyavare. Chaitalo mono don't, combination don't, triple don't, Chaitalo don't, General, every A1C Jara, General Tuyavare. Weight neutral Clean Brain, Shinji Kama, to a weight neutral weight loss down, Ya 90 years out, to Shiavare. Any stage of kidney function, no, best stage, so General, those who Mapion leve, such a lecha pilu yara to Yavare. Cardiovascular, safety days, row, the study Linaglipka, not you pedama, not no Timbiatara to Yavare. Any Chide renema. Below GFWP, even end-stage renal disease, those who Piaoles Yamluau, a chado, TV4, those who Piaoma, Chipare. Liver disorder in Malay, Piluya is what we are. Now, efficacy in just like Sitagliptin Luwe, General, efficacy 0.7 to 0.8 Jara, to Yavare. No, General long-term data, treatment safety, Upiatara, to Yavare. Safety in General, again, when you trap it, safety out to Yavare. Advanced ratio and nasopharyngeal ratio, cardiovascular, let's see pare. Once daily, with or without food, convenient lepare, primarily excreted by a bioencapsulated renation 5% no dose adjustment in the renal and liver. The Linaglip, General, the no, General Totogo, Simbies or Tonuya, to shower. So, my recommendation are when you see a patient with type 2 diabetes, the practitioner must simply ask the question, what is my priority with this patient? Clearly, glycemic control is always a priority, but if cost is a major consideration, certain drugs are preferable. If the goal is to minimize the cardiovascular risk reduction, you can choose the SGLT2 or GLP-1. There's a documented CV benefits are preferable. So our duty is, are you follow the guideline algorithm or I go for individualized treatment for each patient? So individualized the check in you don't need to let's see general individualized treatment is the best option for the choosing the general medications or now so me do serious therapeutic choice evidence based mainly glycemic control organic chain hypoglycemia side effect no weight you cost effectiveness will be nearly cheaper to lower the jamlo no general no recommendation are metformin glycine same metformin glycine no well control so metformin glycine parglisone or sitaglip or SGLT2 dilomyo to be mainly general individualized for mamuti to Jason Pity throughout Timbiadi, General Yimbaga, performing glycine to teach at Timbiadi, the Bama, emphasize Luchinaga, the raw DV4, but though Genesis Male, General Conania Shinia, Lago, General Kawapite, Cyphel, Nere, no, General Wikilam Yahu, cardiovascular safety, the Jamlu second that no line in it, no tone in it. Keluda zita tatane yameso account me Linaglip ka general nine na the peniam so conveniently tone nine so timbia in the conchopiadi, Chizumia Maria.
Thank you very much, Professor Kuko, for your very comprehensive talk as usual. So I would like to ask audience to type your questions in the chat box, and we will come back to you, Professor Kuko, after the second speaker for Q&A session. So this is the time for our very famous, prominent Indian endocrinologist, diabetologist, and medical researcher, Padma Shri Dr. Shashank Joshi. I think we have met once before in Mandalay, and then I still remember your talk. So he is Dr. Joshi. He is currently working as Dean of Indian College of Physicians, Chair of the IDF Southeast Asia region, Senior Consultant Endocrinologist in Lilavati Hospitals, Mumbai. And Dr. Joshi is the former president of too many associations like Association of Physicians of India, API, Endocrine Society of India, the Research Society of the Study of Diabetes in India, RSSDI, and All India Association of Advancing Research in Obesity. And in addition to the prestigious award Padma Shri, he is also a recipient of the International Clinician Award given by American Association of Clinical Endocrinologists, AACE. And he has delivered more than 200 orations nationally and internationally. And he has published more than 100 books and monographs and over 800 research publications. How can he find the time? And he is also the senior editor of Endocrine Connection Journal and also the editor of Practical Medicine. So we are very eager to listen to Dr. Joshi, and he is going to deliver with the topic Evidence to Date, Implications of Choice of DPP4 Inhibitors in Type 2 Diabetes. Please do welcome Dr. Shashank Joshi. Thank you.
Thank you, madam. Thank you, Professor Coco. I do remember quite a few years back, probably 15 years back, I had gone to Mandalay. I had also been to Yangon. And I hope that this COVID goes quickly so that I can come and visit your very beautiful country with nature. And I'm really delighted for having me here. And I would love to have my slides on board. I must at the onset thank people from, I think this is not the first slide. Yeah, previous slide, please. Yeah. From Zaidas Kadila, my good friend Ramnathan and all other people from Myanmar and Dr. Ashok Jaiswal and everybody. So I think Professor Coco has done everything. He has given you a very nice overview of diabetes management on all aspects, including the guidelines from Myanmar. What I'm going to do in the next 30 minutes is giving you the gliptinization of type 2 diabetes. What is the implication of choice? And I'm very delighted and happy that Myanmar will have its made in Myanmar gliptin, which is Myglip or the Linagliptin. So next slide. So I'm going to talk about evolution, how diabetes drugs evolved and how they were simple, direct to complicated strategies. What are the gaps in the older anti-diabetic treatments or existing anti-diabetic treatments? Why have gliptins become such a promising agent? And what is the evidence on efficacy, safety, and long-term use of gliptins? And then we'll focus and narrow down our focus on linagliptin and type 2 diabetes. So that's what is going to be the simple 5-pointer. I'm sure all of you all have joined in large numbers, and I wish you in advance Merry Christmas and a Happy New Year 2021. And I also want to wish all of you all safe health and a de-COVIDized time in the new normal, as they call it. So these 5 pointers, today you will listen something from me. Whatever you listen from me and Professor Coco and Madam in the panel discussion, you will learn something. Whatever you will learn, you should adapt it into your day-to-day practice. So that's going to be the endeavor on these 5 points. Next slide, please. So clearly we need to see that in 1920s, and we are now nearing 100 years of insulin. Next year will be 100 years of insulin discovery. And that was the only treatment of diabetes available in 1920s, except diet and exercise. By accident, the sulfa antibiotics in the World War, they discovered that they cause hypoglycemia, and that is how sulfonylureas were discovered. In 1970s, the insulin receptors were discovered, and then of course we had the second generation sulfonylureas. We had the GLP-1s being discovered, and metformin actually are old agents. They were also 60 years old, but they were reborn in America in 1990s with glinides. But it was in 2000s really that we got the GLP-1 analogs, the gliptins, and the SGLT2 inhibitors. So the last 20 years, we have really seen the birth and the evolution of GLP-1, DPP-4 inhibitors or gliptins like Myglip and SGLT2 inhibitors. Next slide. So clearly, you can see that our focus today is on the next generation agents. They are gliptins, which are the most safe agents on planet Earth. They compete with placebo. You don't need to think. You can have any type of patients, whether it's a cardiac patient, a renal patient. You can give a gliptin like Linagliptin, GLP-1 agents or SGLT2 inhibitors. Next slide. So Professor Coco very nicely told us that the center point of anti-diabetic therapy after lifestyle is metformin, metformin, metformin. And the old treatment of diabetes, the simple insulin secretagogue therapy was sulfonylurea, like gliclazide he showed you, meglitinides like mainly ripaglinide, and then pioglitazone. They were the old therapies. And the complex or the new therapies are GLP-1 agents, gliptins, and SGLT2 inhibitors. And if nothing else works, then we give insulin. So that is the strategy of diabetes. Metformin is still the centerpiece. Then we have the old therapy of sulfonylurea, glinides, and pioglitazone. And then you have the new therapies of GLP-1 injection, gliptin oral, SGLT2 inhibitors oral. And then, of course, if nothing else works, it's insulin. Next slide. So obviously, Professor Coco highlighted this, that the older generation agents cause a lot of peak and valleys, glucose excursions. They cause the valley as hypoglycemia. They cause weight gain. They are injections sometimes, and they can also give cardiovascular risk. So that is the challenge with the older therapies. Next slide. So you can see when the sugar drops down and all our patients are scared about hypoglycemia. And that's what I'm saying, that people who have at least one A1C test done with more than 8% have recorded in 90 days after addition of a sulfonylurea to metformin will have some hypoglycemia. So minute you get an episode of hypoglycemia, your glucose excursions go haywire, your glycemic variability goes haywire, and you can have data from ACCORD study, VIDT study, advanced study to show that hypoglycemia makes an impact and makes glucose control worse. It disrupts glucose metabolism, and it can impact and cause cardiac arrhythmia, sudden death, and even overall death and mortality. Next slide. The other challenge which we face when we give insulin or insulin providing therapies is weight gain. And we have seen that when we give treatments which are insulin providing therapies like sulfonylureas, like pioglitazone, like insulin, you will get gain of weight. And this is illustrated in this slide very nicely. Next slide. So weight gain is the second problem. Hypoglycemia is the fourth problem. And then we know that sulfonylureas can have cardiovascular risk, which has been seen in a lot of studies, that when you see that there is a small risk, intermediate risk, and high risk of cardiovascular events, and there's always been a link between SUs and some form of cardiovascular impact. Next slide. Insulin has its own problems. There is stigma with injections, lack of confidence, allergic reactions, lipodystrophy, hypertrophy, hypoglycemic events, and needle stick injuries. Next slide. So obviously, now we will focus our attention to the new age therapies. Next slide, which is like gliptin, GLP-1 agents, and SGLT2 inhibitors. Next slide, please. So clearly we know that in current management of type 2 diabetes, there has been a significant global impact on incretin backbone. So the new age therapy of diabetes is on the incretin backbone. Oral GLP-1 is not yet available. So it's injectable GLP-1 and oral DPP-4 inhibitors. Next slide. Can I have the next slide, please? See now what has happened because of so much of webinar, even the computer is tired, even the system is tired. So you see how slowly the slides are moving. I am talking fast, computer moves slow. If I talk slow, computer moves fast. This is the new normal. So we have to all adapt to these new normals. So the new anti-diabetic agents today are, from the oral standpoint, are SGLT2 inhibitors like empagliflozin, dapagliflozin, canagliflozin, ertugliflozin, rimogliflozin. And then we have the DPP-4 inhibitors like sitagliptin, saxagliptin, linagliptin, vildagliptin. And then, of course, we have the GLP-1 receptor agents. Orally, semaglutide is also available. But that won't be available in Myanmar or India also. So what we are going to talk today is a lot about linagliptin. But these are the new anti-diabetic agents. Next slide. So let us look at the role of gliptins. Next slide. So we all know incretin therapy. When we eat food, and we are all hungry now because it's around lunchtime, the food enters the intestine. And when it enters the intestine, then it releases from the L and the K cells in the intestine, GLP-1 and GIP-1. And this has a very short half-life. And that will go to the alpha and the beta cells of the pancreas. What it will tell the beta cell is, when the sugar is high, then the beta cell is stimulated. So increased glucose uptake by peripheral tissues. So it will make insulin when there is hyperglycemia. But it will not make insulin when there is no hyperglycemia. So it will reduce high sugar to normal, but will not reduce the low sugar. So there is no hypoglycemia with gliptins. So they switch on the beta cells and they switch off the alpha cells. Also, what happens during diabetes is the alpha cells make too much of glucagon. And when they make too much of glucagon, the glucagon stimulates the liver. And the liver has hepatic glucose output. So there is glucose diarrhea from the liver, which is called as hepatic glucose output. And that is reduced. So what does a DPP-4 inhibitor do? When the DPP-4 inhibitor, when it is a serine protease inhibitor, it blocks the enzyme from being degraded to GLP-1 and GIP. There will be more GLP-1 and GIP available. That GLP-1 will stimulate the beta cell to make insulin when the sugar is high, but not make insulin when the sugar is normal. That's number one. Number two, it will switch off the alpha cell so that the glucagon excess is not there. And when there is not too much of glucagon, when there is excess glucagon, you get hepatic glucose output, you get liver glucose diarrhea, and that happens at night. So remember, our fasting sugar, which we do every day, is a reflection of the overnight hyperglycemia and the hepatic glucose output. So gliptins switch on the beta cells when there is hyperglycemia and switch off the alpha cells so that the excess glucagon is not made, and therefore the glucagon doesn't stimulate, and therefore there's decreased hepatic glucose production, and thereby the fasting and post-lunch glucose comes down. Next slide. So obviously I told you that the gliptins inhibit the substrate and they act as a serine protease. So they have a lot of effects. They have an impact on the peptide Y336. So you feel less hungry. Okay. They also have an impact on insulin secretion and glucagon. They also have an amide which reduces the glucagon, and overall they reduce the fasting, postprandial, no hypoglycemia. They are weight neutral. They can cause a weight loss sometimes. Next slide. So obviously they also protect the beta cells from apoptosis. This is data to show that in animal studies, the DPP-4 inhibitors actually cause new beta cell generation, neogenesis of beta cells, and they prevent beta cell death. So they prevent apoptosis of beta cells. So they don't allow the beta cells to die, and they protect the beta cells. That's the unique proposition of DPP-4 inhibitors. Next slide. So there are various recommendations, and Professor Coco has very nicely told you. Go to the next slide. You're absolutely right. There are various recommendations which Professor Coco took us. He actually showed us this 2020. Actually, 2021 recommendations are also out, but because we are in December of 2020, we know that if there is a high cardiovascular risk or very high cardiovascular risk, heart failure risk, CKD risk, then probably we look at a SGLT2 inhibitor or a GLP-1 analog. But most of our patients, cost is an issue. There is a compelling reason for weight loss or no weight gain and no hypoglycemia. Our concern as a practicing doctor, every day you see patients in the clinic. We don't want hypoglycemia, we don't want weight gain, and we want it to be effective and safe and cost effective. And there the gliptins are right up there in the pecking order. Next slide. So when there is a compelling need to minimize hypoglycemia, we have a DPP-4 inhibitor right there. And even if you have an GLP-1, SGLT2 inhibitor or a TZD, again, gliptins come as a perfect choice of second and third line agents. So gliptins can be used any time of diabetes, when you are on oral drugs and including when you are on insulin. So remember one thing, you can use gliptins early, you can use gliptins in mid stage of the disease, you can use gliptins in the late stage of the disease, you can use gliptins with comorbidities, you can use gliptins with insulin. So you can use gliptins anytime and they will work. They are sustained, durable, and they work anytime. So that's the big beauty of gliptins. Next slide. And the more carbohydrate you eat, the better are the gliptins which work. So obviously you can see that whenever, even if atherosclerotic vascular disease predominates, gliptins are right up there, particularly linagliptin, because it is CV safe. It has shown to the planet Earth that now there are 2 cardiovascular outcome trials of linagliptin, which I'll discuss later, showing that they are very safe for the heart. Next slide. And obviously gliptins are also there when heart failure predominates. Of course, you can't use saxagliptin because or allogliptin, but you can use linagliptin. Next slide. For weight gain or promoting weight loss, gliptins are right up there as stable agents. Next slide. And even for cost, gliptins are right up there. Next slide. So obviously, if you look at the ACE 2020 guideline again, gliptins can be used if the A1C is below 7.5. This is again what Dr. Coco told us. It can be used as a perfect combination of dual therapy of gliptin, metformin, and it can be used also as a third line treatment. So whether your A1C is below 7.5, no hypoglycemia, between 7.5 and 9, no hypoglycemia, gliptins are there everywhere. So they are very unique drugs which can be used. Next slide. So the advantages of gliptins are they have no hypoglycemia, they are weight neutral, they can be used in renal and genitourinary issues, they don't cause any gastrointestinal side effects, they are safe for the heart, for atherosclerotic vascular disease, for heart failure, they are safe for the bones, and they don't cause any ketoacidosis. So even compared to a GLP-1 agent or a SGLT2 inhibitors, the safest agents on planet Earth today is an DPP-4 inhibitor like linagliptin. Next slide. So clearly you can see here gliptins stand out. Next slide. And if you see the wheel of management, whether it is age, BMI, CKD, duration of diabetes, established cardiovascular disease, cost, glycemic status, or hypoglycemia, gliptins are there everywhere. So that's something which we know and we recognize better. Next slide. So obviously, if you look at the patient-centric approach for dual therapy, triple therapy, elderly people, geriatric patients, gliptins are a standard of care. Next slide. So if you look at the Myanmar guideline, and Professor Coco very nicely said that even in the Myanmar guideline, you start with metformin. If you have not controlled, you can use metformin with a sulfonylurea or a glitazone or a SGLT2 inhibitors. But metformin and gliptin is right up there in the pecking order. And if the A1C is more than 10, then again you have metformin with gliptin. So gliptins are a part and parcel of all algorithms, including Myanmar guidelines. Next slide. Gliptins have advantages. Why should you use linagliptin? Why should you use Myglip? Because it will get your glucose control quick and fast. It will meet your A1C target. It will have no up and down sugar. So sugar won't go up and down. No hypoglycemia. Safe for the heart, safe for the kidney, may be beneficial for the kidney. So you have a drug, good for the heart, good for the kidney, no sugar which goes low, no glycemic excursions, can get you to an A1C target, and you can get good glycemic control. Next slide. So obviously, you know that lower is the A1C to 7%, lesser is the micro and neuropathic complications, and also lesser are the macrovascular complications. So we have to treat to a target, and we know the targets are individualized. If there's a young patient, less than 10 years of duration, we want to go to 6.5. The only fear is of hypoglycemia there, and that's why gliptins are right up there. If there is a senior citizen with limited life expectancy, long duration of diabetes, you can relax your target to even 7 to 7.5 sometimes. But overall, for non-pregnant adults, the glycemic target is 7%. Next slide. So what is unique about gliptins is they act very fast. And this is linagliptin data, where you can see early intensive glycemic control. They get the glucose down very quickly. And that's the unique advantage. Early intensive glucose control. So they are fast glucose regulators. Next slide. And you can see that most people who take a gliptin can achieve a target below 7%. So you can treat to target below 7. So when you take an aim on a diabetic and you want the A1C below 7%, gliptins are right up there on the pecking order. Next slide. And they don't cause up and down sugars. So they have a lot of avoidance of glycemic excursion. This is data talking. Next slide. They don't cause hypoglycemia. For example, the risks and odds ratio of hypoglycemia in a gliptin is 0.3, glitazone is 0.5, and sulfonamide is 2.1. So they actually lower the risk of hypoglycemia. Next slide. And there are CVOTs. Examine and Saver-Timmy showed the gliptins are safe for the heart, but there's increased hospitalization of heart failure. And that is why Saxa and Aloe we don't consider. TCOS showed that they are neutral. And there are 2 trials of linagliptin. It's the only gliptin on planet Earth where you have seen a 3-point MACE of 7,000 and 6,000 patients with linagliptin, Carmelina and Carolina trial, showing that it is very, very safe. One is head-to-head with glimepiride, other is head-to-head with a placebo. So you have both a placebo-controlled RCT and active compared RCT. And that's why linagliptin is unique on the evidence-based piece. Next slide. So obviously, if you look at the CVOT trials, Examine is for allogliptin. There was a risk of hospitalization for heart failure. Linagliptin is Carmelina and Carolina. Very safe. Saxagliptin, again a risk of heart failure hospitalization with saxagliptin. Sitagliptin is neutral. And vildagliptin, there is no CV outcome at all. Next slide. So as I told you, allogliptin and saxagliptin have a risk for hospitalization for heart failure, which is not there for others. Next slide. And obviously, it's not a class effect for all of them. Next slide. And clearly, you can see that it's a neutral cardiac effect. So incretin-based therapies don't affect the risk for heart failure. Next slide. And if you look at long-term impact on elderly at cardiovascular risk, and that is what linagliptin has shown us consistently, that it is very, very safe for senior citizens above 75. Even after the first myocardial infarction, very safe agent. Next slide. And they are very safe on the kidney. Linagliptin is a renal gliptin. So it actually improves people with macroalbuminuria because it's a renal gliptin, and it actually impacts the TGF beta. Next slide. and it sustains the kidney safety effect. So it is nephroprotective even up to 4 years. And this is again data from Linagliptin demonstrating beyond reasonable doubt the impact of Linagliptin on the long-term renal benefit. Next slide. So obviously, how do they protect the kidney? We know that when we block the endogenous substrates of DPP4 inside the kidney, they are like SDF1 alpha, GLP1 and others. On the kidney tubules, they cause diuresis and natriuresis. So they leak out more water and sodium. On the renal hemodynamics, they increase the GFR and reduce the glomerular hyperfiltration. On the kidney risk factors or renal risk factors, they decrease blood pressure, inflammation, dyslipidemia, and oxidative stress. But most importantly, if you do a kidney biopsy in people treated with Linagliptin, the glomerular sclerosis reduces, the tubulointerstitial fibrosis reduces, and the podocyte loss is reduced. Next slide. So if you compare all the gliptins, the most selective, highly selective gliptin is Linagliptin, 40,000 selectivity of DPP4 over D2E8, and more than 1 lakh DPP4 over DPP9. They increase the incretin levels 2 to 3 fold. 5 milligram once a day is the dose. Half-life is more than 100 hours. No significant metabolism and biliary route of mechanism. So Linagliptin is the most selective gliptin over 8 and 9. It increases the incretin levels by 2 to 3 fold. It is once a day with a robust half-life of 100 hours and no impact on excretion or metabolism. Next slide. So Linagliptin is a unique gliptin. Okay, it can be given once a day. It improves glycemic control early and quick. No hypoglycemia, safe for the heart, safe for the kidney. And for the kidney, it actually may be more useful. Next slide. So the early and sustained benefits are now clear-cut. They are sustained up to 180 weeks. We have very, very good data to show that Linagliptin works. Next slide. And when you add them to therapy to metformin or insulin, they keep working. Next slide. And one thing is very clear-cut. When sulfonylureas are no longer effective, and this is a study which is a switch study, and you give Linagliptin, you can see that whether it is glimepiride, glibenclamide, gliclazide, you can see the A1C drops. So it actually is a very efficient drug even when there is resistance to sulfonylureas. Next slide. And you can see even head-to-head with sitagliptin, Linagliptin is the gliptin of choice and it scores over sitagliptin. Next slide. And when you combine it with empagliflozin, it has a unique impact which is long-term. Next slide. Carmelina showed that it is not only safe for the heart but also safe for the kidney with Linagliptin, followed up for 2 years and more. You can see this in the graph. Next slide. And it is very, very kidney protective. It reduces the risk of progression to albuminuria, and independent of the GFR, you can see that Linagliptin works. Next slide. And you can see the impact on the urinary albumin excretion over 12 and 24 weeks. You can see Linagliptin improves the kidney function with improvement of the A1C levels. Next slide. And very low risk of hypoglycemia. So it doesn't cause any hypoglycemia. Head-to-head Carolina data is there to show no hypoglycemia when it is compared head-to-head with glimepiride, which has significant critical life-threatening hypoglycemia. Next slide. So clearly you know that the older insulin-based therapies, providing therapies apart from metformin, have dominated diabetes therapy, which are changing now, because they can cause cardiovascular risk, weight gain, and hypoglycemia. The newer treatments like gliptins are here to stay. They are no-brainers. You can use them as first line, second line, third line, and anytime. I prefer to use a gliptin right away as a first or second line with or without metformin. That's my standard of care. You don't have to think. You don't have to look at the patient, the profile, he's lean, he's obese, he has got kidney problem, he has got liver problem, he has got heart issue, anything. If you don't want to think, use Linagliptin. You will never go wrong. Next slide. Clearly, gliptins work fast and are sustained and durable. They don't cause up and down sugars. They don't cause hypoglycemia. They are safe for the heart. And uniquely, Linagliptin is a kidney gliptin without hypoglycemia. Just 5 milligram once a day, and that's what you have. Next slide. So what I have tried to give you is a overall glimpse of the gliptin world, and I have allowed you to continue from what Professor Coco very nicely put it. So Madam set us the stage and Professor Coco explained to you in your language, and all I have done is focused what Professor Coco said in a little more deep dive so that you can get a better understanding in the gliptin world of Linagliptin. Thank you for a patient hearing. I'm sure we are all looking forward to a nice panel discussion. I'll be happy to answer any questions related to my topic, but or also any topic in diabetes management which you would like to listen. Thank you so much.
Thank you very much, Dr. Joshi, for your very insightful talk. Yeah? So now I think the audience is eager to ask you, and now we are going to get the questions. So before getting the questions, I would like to know your opinion regarding the use of DPP4 inhibitor in hospitalized patient in general, and as well as the use of DPP4 inhibitors in patients with COVID infection.
So in hospitalized patients, when people are eating well and then they can eat per orally, you can use a gliptin. And Linagliptin is very safe because it's a renal gliptin. In COVID, you know SARS-CoV-1, then we know MERS, and we know SARS-CoV-2. MERS attacked the body through a DPP4 receptor. So we all know that DPP4, which is a serine protease, is like the ACE2. We know SARS-CoV-2 docks into the body or the lungs through ACE2. That's a docking receptor. Similarly, MERS, which is another coronavirus, was docking through the body through the DPP4 enzyme. So there is data to suggest that if you use a DPP4 inhibitor in COVID hyperglycemia, it can not only be useful for reducing diabetes, protecting the kidney, protecting the heart, but also maybe anti-COVID. So there is ongoing data, and I have used it in our population, where we have used both metformin and gliptins, including Linagliptin, to be anti-COVID. But this is all anecdotal, but there's good science in it because, as I told you, one of the putative receptors on the SARS-CoV-2 is DPP4. DPP4 is a serine protease. So anytime you block a serine protease, it actually protects you from cytokine storm. So people who are diabetics, you know, diabetes is a vulnerable group in COVID. So if you are a diabetic and if you're on a gliptin metformin combination, you are less likely, even if you get COVID, to get complications of COVID like cytokine storm. So probably there is a role for DPP4 inhibition in progression from a mild or moderate COVID into severe COVID, and it may prevent cytokine storm. But of course, we need more data to substantiate this, and there are ongoing trials.
Thank you so much. So you are using DPP4 inhibitors from the very beginning of all kinds of COVID, including the ICU patient?
So if the patient can eat orally, we use it. If the patient is in the ICU, we give insulin. Let me be very transparent. Inside the ICU, they need a lot of insulin. Once they start eating orally, even on Riles tube, we still use insulin. Once they start eating orally, then we add a gliptin. Because then you can add a gliptin, and many of these patients, their creatinine is high. So then adding Linagliptin becomes the advantage. But usually during the critical ICU phase of COVID, it is insulin. After and before, you use a gliptin.
Okay, thank you so much. I think you have clearly said in your lecture, DPP4 inhibitors are safe in every aspect. But one doctor from the audience asked specifically about the use of DPP4 inhibitors in cirrhotic patients. His question is, can all DPP4 inhibitors safely be used in cirrhotic patients? Which DPP4 was preferred in cirrhotic patients? That's the
If you
question.
see the labels, Linagliptin has a label to use it in child's class 1 and 2. But when there is child's class or child PUC class 3, no agent, no oral agent is approved. So if you have end-stage liver disease with child's PUC's classification of portal hypertension stage 3, then you should use insulin again. No oral agent should be used. So let me be very clear. They are safe in all the indications. Linagliptin, though it has a hepatobiliary route of excretion, is actually having some hepatoprotective impact. So is sitagliptin. Let me be very transparent here. You should never use vildagliptin because vildagliptin can increase the liver enzymes and can be detrimental. It's liver toxic. That is why US FDA never approved vildagliptin because 100 milligram of vildagliptin caused damage. So remember that gliptins can be used in early stages of liver cirrhosis. In late stages of liver cirrhosis, when you have obvious portal hypertension, esophageal varices, ascites, please don't use them, then use insulin.
Okay, very clear answer. Thank you. And the next question look like a case scenario in MRCP. And her question is, 50-year-old lady, uncontrolled diabetes, A1C more than 10%, body weight 84 kilogram, normal renal function. She is currently on Mixtard 140 units per day. She can't afford a GLP-1 receptor agonist, and she's intolerant to metformin. And DPP4 inhibitor has not been started because of abdominal pain. She cannot afford SGLT2 either. So fasting blood sugar is 200 to 300 and random sugar is 300 to 400 milligram per deciliter despite using Mixtard 140 units per day. How would you proceed glycemic management in this lady?
So
Thank
this
you.
lady is obese and is clearly insulin resistant.
Yeah.
And because this lady is insulin resistant, it's a no-brainer. You need to add an agent. You can't use metformin because there is intolerance. You can't use a AGL2 inhibitor, but it's not going to work because it's there. But you can use a pioglitazone. You can use a linagliptin. You can use definitely other agents. So I don't think you cannot use agents. You can use agents in these patients, and the insulin requirement will come down. So even if your A1C is more than 10%, and even if the patient is intolerant to metformin, you can use pioglitazone. Actually, Zydus makes a drug called saroglitazar, which is a glitazar, which can also be used in this patient because it's very good for insulin resistance. You can definitely use a linagliptin, no question asked about it. You can occasionally try a sulfonylurea because sulfonylurea also reduces a little bit of the insulin requirement. So I think this lady needs first lifestyle counseling because if the lifestyle works, all drugs work. If lifestyle doesn't work, no drug works. Lifestyle counseling, eat slowly, eat on time, eat right, do walk for 10,000 steps every day, do some physical activity, then probably add a linagliptin or a sulfonylurea, add clearly a pioglitazone. I will definitely add if cardiac wise there is no contraindication. Okay, and maybe with these two the Mixtard requirement will come down to maybe 20 units or 30 units, and later on we can even take off the insulin, but that may take time. So usually such patients need 3 drugs or sometimes 4 drugs, and usually if they are motivated, they are monitored, within 3 to 6 months you can actually reverse the whole trend. But if it's all again how much the patient cooperates with the doctor. So I think, ma'am, it's very doable. We see these patients every day. I really like the way you're asking this question, but this is something which we can do every day and use the drugs which you have to do, and you have to individualize it. So you have to sequentialize it. So you don't have to add everything at one go. You can add 1 or 2 drugs, see how the patient responds. Is the insulin requirement coming down or not? Also remember, when you use a lot of insulin, Many a times that insulin is just not working. Because what happens when you give insulin, you feel more hungry. So you eat more. When you eat more, then you take more insulin. So the requirement just keeps on climbing up. So you need to modify yourself and you need a braking agent. Whenever there is insulin resistance, you need a braking agent. Metformin would have been ideal, but it's not possible. Please use at least 15 milligram of pioglitazone, even if there's a cardiac. Metformin is, pioglitazone or saroglitazar. I don't know whether saroglitazar is available in Myanmar. And then, of course, we have this Linagliptin. We can definitely use it. I have used gliptins a lot in this metformin intolerance. See, remember, 10% of our people get metformin diarrhea or metformin intolerance. They just can't handle metformin. And we know the why. It is pharmacogenomic. We have OCT1, organic cation transporter 1. That's a genetic defect. So some people, like Professor Coco or ma'am or me, I may be metformin intolerant if I take metformin because I might have a defect in my OCT1, organic cation transporter 1. And if there is a pharmacogenomic defect, then I'm not going to handle metformin. This is what this patient may have. And then I may try a linagliptin, I might try a gliptin, I might try a sulfonylurea, and I can see whether the insulin requirement comes down. Also do a C-peptide. Because if the C-peptide is low, this patient doesn't have beta cells on board. Even if there are no beta cells on board, there are 3 agents you can still use. Okay, you definitely then you need insulin. To reduce the insulin requirement, you can use still a glitazone. You can still use a gliptin despite of having no C-peptide. So again, remember, absence of C-peptide means always use insulin, but you can co-prescribe this and you can sometimes use alpha-glucosidase inhibitors. So these 3 agents can be used even otherwise. So that is how I would approach this case, madam. I hope I'm clear.
Okay, let me clarify one or two things. And thinks the candidate concern is because of her body weight of 84 kilogram. I think she is reluctant to put her on pioglitazone and sulfonylurea. Would you worry about the body weight gain with pioglitazone?
I would not worry in this lady. Why? I'll tell you, madam. Because what happens is that insulin resistance has to be broken. So to break the resistance, the pioglitazone redistributes fat. So I may not give the high dose. We can even use 7.5 or 15 milligrams. But that insulin of 140 units will make her from 84 kgs, 100 kgs soon. So you need to remember that you need to serially follow up this patient. I understand that there's a reluctance to use sulfonylureas because of hypoglycemias. So probably I will use a gliptin first, but gliptin may not break the resistance. So to break the resistance, I either need metformin or a glitazone. So I still would use 7.5 or 15 milligram with a gliptin. And I think the insulin requirement will come down by more than half. But it's a good question you're asking. And also remember, pioglitazone redistributes fat. So actually the good fat, see what human beings are born with limited fat. So let me tell you, as Caucasians, they have more fat cells. We are born with a finite number of fat cells. Then only the fat cells can expand. What happens with, say, somebody from India or somebody from Myanmar? We then make whatever extra fats happens there, we deposit it in ectopic places. What pioglitazone does is it takes away the fat from the ectopic site and distributes it back to the subcutaneous tissue, which is a healthy tissue. So what is happening, even if there is a little extra weight gain, there is a fat redistribution from bad fat sites to good fat sites. So it is still very useful only in exceptional circumstances. But nowadays we don't use too much of glitazone because of the fear of that, of unmasking cardiac failure, of causing macular edema, causing a fracture, causing a swelling of the legs. That is why we don't use it. We use it much less. But exceptional drugs for exceptional circumstances. So this is a rare thing. This is every day you don't see a case like this where you have so many do's and don'ts. So then sometime, but here it will work. I am very certain I have seen people like this and this will work. But as I said, you will have to do mix and match. And we might have to do treatment trials. So, trial and error has to be done here, but I'm sure it will work.
It's very lovely to hear your thought. And let me bring Professor Coco into this discussion. From your pathophysiologic point of view, would you recommend to use insulin secretagogue in a patient using insulin of 140 units? What do you think?
Yes, in that case, as Professor Shashank Joshi said, that is there any insulin resistant because it's already on the 140, right? So that is we need to go down to the insulin resistant first. But I'm not quite confident to give a secretagogues for this patient at the moment for combination because he stay really reluctant to give because of the weight gain, because of the hypoglycemia. So I will be very reluctant to give the secretagogues, but we don't know about some beta cell reserve in this patient. Probably if there is no choice for the internally to metformin intolerance, or we can try for this just to see some preserved insulin in combination with the insulin and secretagogues.
Okay, thank you. And Dr. Joshi, I would like to ask you your opinion regarding the use of hydroxychloroquine in such kind of patient. Would you recommend to use hydroxychloroquine? Thank you.
Hydroxychloroquine is a very spare agent. I don't use it as a first line agent, second line agent, third line agent at all. I use it very occasionally. Where I found hydroxychloroquine in diabetes best is when there is frozen shoulder with diabetes. A lot of our patients with diabetes have frozen shoulder, adhesive capsulitis. You can't take the shoulder up. That is the time, and the sugars are not controlled by 3 agents or 4 agents. So you have a patient who is on, say, metformin, sulfonylurea, gliptin, SGLT2 inhibitors, 4 agents, and patient says, I don't want to take insulin. Then I might add 400 mg of hydroxychloroquine if there is frozen shoulder, rheumatic disease or something. But I don't use it as my first line or my second line or my third line. It's again a rare agent for rare times. There are 2 problems with hydroxychloroquine. One is that we need to be careful for QT prolongation. So our diabetic patients are also susceptible for QT prolongation. And you have to look at again the eyes. So if there is a proliferative retinopathy, or if there's a cardiac QT prolongation, then I have to avoid hydroxychloroquine. I have used hydroxychloroquine for diabetes, and I have presented a paper also in ACE Congress. In brittle diabetics, sometimes it works. In this patient, insulin requirement will not come down. So I will not use hydroxychloroquine in this patient because she's obese. I'm not so sure. Also, hydroxychloroquine can cause sometimes very bad nausea. So people who are intolerant to metformin usually are intolerant to hydroxychloroquine. So remember that as a rule of thumb, that usually people, because again, hydroxychloroquine has an interaction with OCT1, organic cation transporter 1. So therefore, in this particular case, I will not use it. Occasionally, rare cases, I may use it.
Thank you. And we have done some research with OCT1 in our diabetic patient, and we love to share our experience with you sometime. Right.
Sure.
So
I would
shall
love
we
to hear
move?
that.
Thank you. Shall we move on to the next question? And this doctor's asked, she has a chronic patients with a diabetes taking subcutaneous insulin. Now she has edema, hemoglobin A1C 8.8, creatinine is high, 4 milligram, and the unit is 4 milligram per deciliter. And then she wants to know further management of her patient. Obviously, I think she has renal problem. Yeah. Would you like to answer?
Professor, this is DKD, diabetes kidney disease. So this
Yeah.
patient will need a diuretic, will need ACE and ARB, will need some soda bicarb, will need, a whole kidney management protocol with diabetes protocol. And will need renal friendly diabetes agent. So, definitely metformin, if at all is used, if the eGFR is up to 45 or 30, you can not use more than 500 milligrams. Linagliptin can be safely used. Some sulfonylureas can be safely used. Insulin will work longer because the half-life will be longer. So you will have to be very cautious for hypoglycemia. And then we will have to give a kidney protocol. So we will have to give some soda bicarb, some amount of erythropoietin if the hemoglobin is low, some degree of blood pressure medication, some diuretic, like either we'll get to give furosemide or torsemide. So we will have to have a dual approach. And therefore, this is a classic case of DKD. We have to preserve the nephron. And there is a small role for SGLT2 inhibitors emerging in this space, particularly with the Credence trial and with the DAPA kidney trial and the EMPA kidney trial. There is some role emerging there. So it is possible that if based on the eGFR, and here the eGFR is clearly probably below 15, because if creat has reached to 4, it's very likely that the eGFR has dropped below 15. Below 15 eGFR, there is precious little we can do. But if the eGFR is up to 30 and 15 to 30, some SGLT2 inhibitor may also be useful. Linagliptin clearly will be useful. And then, of course, insulin. So for diabetes management, there will be algorithm. For kidney management, there will be an algorithm. We can manage both. And the whole idea is to see that there is a stable creatinine, stable renal function to preserve and save the patient from dialysis. Because if the creat keeps on doubling up, you will end up with dialysis. The other thing is educate the patient on kidney toxic drugs, commonest being painkillers. The biggest problem is when I see a diabetic patient with a creat of 4, they get some muscle pain, they take some non-steroidal anti-inflammatory drug and the creatinine becomes 8. And then they go on dialysis, number 1. Number 2, sick day regimen. Whenever they fall ill, they should go to hospital, get admitted and take supervised drugs. And the third thing which they need to do, because whenever they get diabetic kidney disease, they're very vulnerable. They should always take vaccination. They should get hepatitis B vaccine, they should get a pneumococcal vaccine, and they should get vaccinated and a flu shot. So all these things are important. So there are 3 aspects of care: prevention of complications and vaccination, then of course kidney care and diabetes care.
Thank you so much. And another question is interesting. She asked, she has a patient with 65-year-old with history of pancreatitis. She can give DPP4 inhibitors or not?
No, I will avoid. Simple. If there's an acute pancreatitis episode, I will not give.
What about history of pancreatitis?
So if there is a history of documented pancreatitis, I would avoid the agent. See, I don't want to expose somebody when somebody has a history. That patient will keep on coming back to you. Nowadays, people sit on Google, they sit on internet, they have this WhatsApp university. I'm sure even Myanmar, now internet is much more available than when I came there almost 15 years back. So, I think it's better to avoid.
Thank you. And I would like to extend that question to the use of DPP4 inhibitors in patients with gallstones, because, gallstones are quite common in our part of Bharat. So would you like to use DPP4?
So for a silent gallstone less than 2 centimeters, it depends on the location of gallstone. Lot of people are having, so if somebody has a BMI of more than 40 with a gallstone, which is present and is silent, sitting there, there is no biliary sludge, there is no intrabiliary hepatic radicals involved. And if there's a simple isolated gallstone less than 2 centimeters, it's quite okay to use a DPP4 inhibitors. But if there's a biliary sludge, okay, with obesity and BMI above 40, I will again avoid. So remember, we need to be logical. Remember, in this patient, independent of the anti-diabetic agent you will use, you might get pancreatitis. So it is not at all linked to gliptin at all. Even if you use a sulfonylurea, you can get pancreatitis. So remember that this is a pancreatitis vulnerable patient. But a simple small gallstone 1 centimeter sitting inside the gallbladder quietly without any biliary sludge, I'll use a gliptin. I don't have a challenge.
Okay. Will you use with multiple gallstones?
With multiple gallstones also, if they are sitting in the gallbladder quietly and they have been there for the last 10 years, I may use. Okay. But as I said, it has to be very individualized. I'll see the LFT, I'll see the amylase, lipase. I will not just use it blindly.
Sure. Yeah, there are quite a few questions left. Another question is, sitagliptin has drug-drug interaction with statin. So sometimes it can cause statin-induced myositis and rhabdomyolysis. So what about linagliptin? That does have any interaction?
So linagliptin doesn't have any drug-drug interaction with statins at all. and even the sitagliptin statin interaction is very rare, but statins itself cause a lot of myositis independent of the gliptin. So gliptins are not linked to statins in that way.
Mama, can we repeat the question?
Yeah, there are not very much question left. They've been praising about your RSSDI wheel. They are very appreciative of your RSSDI wheel. Yeah. Can you hear me?
Yes, I can hear you. Yeah.
Yeah, right. And then another thing I would like to ask a question is the is a question from last show. He wants to know Linagliptin metformin combined pill twice a day. That's what that's his question. Have you ever heard of Linagliptin metformin combined pill twice daily? I don't know. I have no idea.
Yes. So we have this pill, which is 2.5 with 500 or 2.5 with 1000 in the breakfast and dinner. So we have that tablet available in India. And I'm sure that Zydus will have that available for Myglip also in Myanmar soon.
Okay.
But we don't use 5 milligram. We use 2.5 with 500, 2.5 with 1000.
Right. So it can be used twice a day.
Yes, Professor I.
Okay. And okay. If I do remember right, I have read somewhere regarding the DPP4 inhibitors. There are some racial factors which governing the efficacy of DPP4 inhibitors.
Yes.
Please give your comment.
Absolutely. So if you eat more carbohydrate, if you use more noodles, more carbs, then you respond better. So there is data that Indians, Koreans, Chinese, and Asians, all of us, we respond better to gliptins compared to Caucasians. They eat less carbs because it is the exposure of the carbohydrate on the intestine which increases GLP-1. So what response we see in the US, the gliptins only work and reduce A1C by 0.6% to 0.8%. While if you see in India, the A1C drops down to 1%. So more is the carb you eat, the better is the response. Less is the carb you eat, the less is the response. So there is a racial predilection. So Asians as general, which is us, we do better respond compared to Caucasians.
Thank you. And I think that would be the last question. And sorry to bother you. And then I would like to ask Professor Kuku as well. Sometimes we are troubled by fasting hyperglycemia without much high postprandial blood glucose. In that case, we intend to use metformin, pioglitazone, and then sometimes basal insulin. But patients are very reluctant to use insulin because of the fasting hyperglycemia alone. In that case, your DPP4 inhibitor will be beneficial for it. And if that's so, which time of the day would you like to prescribe DPP4 inhibitor for combating the fasting hyperglycemia? Thank you.
DPP4 inhibitor can reduce the hepatic glucose output as well. So it can be used in the fasting hyperglycemia. So I saw if we have fasting hyperglycemia, but some people, when they look at the HbA1c is normal or is within the normal limit. So in some cases, we don't need to worry about the fasting hyperglycemia. But if fasting hyperglycemia is troublesome, probably we need to use the alternative one is before inhibitor, we can use it. But if you say Linagliptin is a long half-life, I rather think that this is it's 24-hour. You can take anytime you like, but most favorably we would like to give in the evening time. So I would like to hear about the Professor Shashank Joshi.
Yes, evening is always better because the hepatic glucose output works in the night. So giving them in the evening or bedtime works. Whether it's metformin, gliptin, whatever you give at night works better on the next day morning fasting sugar because the hepatic glucose output is more at night.
Thank you. Thank you so much. So I think now we are about time to wrap up our discussion, right? And so from the talk, we have listened to Professor Coco, and he told us about the various approaches like glucocentric, pathophysiologic, and cardiovascular risk reduction approaches. And we heard from Professor Joshi regarding the beauty of DPP4 inhibitors, especially Linagliptin, and from his talk, we can label Myglip as a anytime drug of the type 2 diabetes. So, and I would like to say, whatever we tried with numerous approaches, we are still a bit far from our treatment target. I think you all have read about the Discover study. It is a little bit depressing because in our Southeast Asia, people with hemoglobin A1c more than 9% are 35% of our patient population. It is it still highlight we are still lag behind our treatment target. So I think it's because of our therapeutic inertia from the healthcare professional side of treatment, and from the patient's perspective, they need to adhere to the treatment. And in that case, the goodwill and effort of the scientists to bring Myglip at a lower, much cheaper cost, I believe, is to relieve the cost burden for our country, which is really a necessity for us. So with that, I would like to conclude our symposium scientific discussion. And I thank you all the people participated in our discussion, and especially Dr. Joshi for sparing your very precious time. And we know that you are very busy with COVID situation in Mumbai, and we do pray for your people to have a better new year with better outcomes. Thank you.
Thank you. Thank you.
Okay. Okay, ဆရာမိုင်းနဲ့တကွာအားလုံးပဲမင်္ဂလာနေ့လေခင်ဗျာကျွန်တော်ကတော့ Zydex Cadila Hacker Division နဲ့ Head ဒေါက်တာနေရွှေအောင်ပါအထူးသဖြင့်ဒီဘွဲဖြစ်မြောက်ဦးဆောင်မှုပေးခဲ့တဲ့ Chair အမ Professor ဒေါ်အေးအောင်ဟောပြောပေးခဲ့တဲ့ Professor ဆရာကြီးဦးကိုကိုဒေါက်တာ Shashank Joshi တို့လည်းကျေးဇူးအထူးတင်ကြောင်းပထမဦးစွာပြောကြားလိုပါတယ်ခင်ဗျာဒီကနေပြီးတော့ကျွန်တော်တို့ Zydex Cadila ကနေကြီးမှုကျင်းပတဲ့ New Product Myglip Linagliptin 5mg launch diabetes symposium ကိုအားလဲတဲ့ကြားကနေပြီးတော့အချိန်ပေးပြီးတက်ရောက်ပေးခဲ့တဲ့ဆရာကြီးဆရာမကြီးများအားလုံးကိုလည်းကျေးဇူးအထူးတင်ကြောင်းပြောကြားလိုပါတယ်ဆိုတော့ကျွန်တော်တို့ Zydex Cadila ဆိုရင်တော့ဖြင့် organizational experience 69နှစ်ကျော်ရှိပြီဖြစ်ပြီးတော့ကျွန်တော်တို့1996ခုနှစ်မှာမြန်မာနိုင်ငံရောက်ရှိတာဖြစ်တဲ့အတွက်ကြောင့်ကျွန်တော်မြန်မာနိုင်ငံမှာတော့24နှစ်ကျော်ကြာတက်တန်းရှိပြီဖြစ်တဲ့ဖွဲ့စည်းတစ်ခုဖြစ်ပါတယ်ခင်ဗျာကျွန်တော်2018ခုနှစ်မှာတော့အလီတက်ထက်ကဲမြန်မာဆိုပြီးတော့ပြည်တော်မှာစေဝါစေုံနေဆောင်ပြီးတော့ကမ္ဘာစစ်မီစေဝါတွေကိုထုတ်လုပ်ဖို့စတင်ခဲ့တာဖြစ်ပါတယ်ကျွန်တော်တို့နိုဝင်ဘာ2020မှာနေစပြီးတော့အလီတက်ကနေပြီးတော့စေဝါတွေကိုစတင်ထုတ်လုပ်ပြီးတော့ကျွန်တော်နည်းနည်းချင်းစီ commercialization စတင်ခဲ့တာဖြစ်ပါတယ်ကျွန်တော်တို့ Nucosia 90လို့ Zyrova 10mg လို့ Zytrin တို့ဟာဆိုရင်လည်းအဒီတက်ကနေပြီးတော့စပြီးတော့ထုတ်လုပ်နေတာဖြစ်ပါတယ် ကျွန်တော် Myglip Linagliptin 5 mg ဆိုရင်လည်းတီလိုအောင်မှာရှိတဲ့ Elite Factory ကနေထုတ်လုပ်တဲ့မြန်မာနိုင်ငံမှာထုတ်လုပ်တဲ့ပထမဆုံး anti-diabetic ဆေးတစ်ခုဖြစ်ပါတယ်ခင်ဗျာဟုတ်ကဲ့Myglip Linagliptin 5 mg ဆိုရင်ဈေးနှုန်းအပြင်လည်းသက်သာမှုရှိပါတယ်ကျွန်တော်မြန်မာ product လည်းဖြစ်တဲ့အတွက်ကြောင့်ဆေးဝါးပြတ်တောက်မှုလည်းမရှိပါဘူးခင်ဗျာဒီနေ့တစ်လုံးပဲတောက်ရတဲ့အတွက်ကြောင့်ဟို side effect အပြင်လည်းနည်းပါတယ် liver cardiac renal အတွက်လည်း safe ဖြစ်ပါတယ်ခင်ဗျာ combination အတွက်လည်း safe ဖြစ်ပါတယ်ဒါကြောင့်မလို့ဆရာမတို့ရဲ့လူနာတွေအတွက်လည်းအကျိုးရှိမယ်လို့ညွှန်လင့်ပါတယ်ခင်ဗျာအားလုံးပဲမင်္ဂလာရှိသောနေ့လေးဖြစ်ပါစေအားလုံးပဲကျေးဇူးအထူးတင်ပါတယ်ကျေးဇူးတင်